It started. It's recording. Sorry.
Yeah. So you can start. Thank you, sir. Thank you so much.
Thank you. So shall I make a start now? Yeah.
Yes, sir. So shall I start with the intro, sir?
Yes, please.
Yes. Good evening. This is Ignatius on behalf of Indian Medical Association, Medical Students Network, and Junior Doctors Network, and it gives me immense pleasure to welcome you all to the Medinfinite Conference 2020 here. It is with great honor that I now introduce to you our speaker for the day, and in fact, our first speaker in Medinfinite, Dr. Prabhu Rajendran, who will be enlightening us about pediatric multisystem inflammatory syndrome in post-COVID patients. Dr. Prabhu Rajendran graduated from the prestigious Institute of the Madras Medical College in Tamil Nadu and has been working in UK National Health Services, NHS, for the past 15 years. He is passionate general pediatrician with special interest in acute pediatrics and holds a postgraduate certification in pediatric gastroenterology from the Great Ormond Street Hospital, University College London. With his interest in child health policies, he works with the Royal College of Pediatrics and Child Health as an RCPCH Ambassador. Sharing an equal passion towards the welfare of the BAME community, he holds the position of Honourable Vice Chairman of the World Tamil Organization, a registered charity organization established with the aim of promoting the welfare of the Tamil community in several aspects, especially in arts and culture. Sir has graciously allotted a dedicated question and answer session towards the end of this presentation. Once again, I will welcome you, sir, to take over the session and enlighten us with your knowledge. Please, sir.
Thanks a lot, Raghu and Roshan. And I take this opportunity to thank the Indian Medical Association Tamil Nadu chapter for inviting me for this session. So as we had been talking about, my talk today is going to be about understanding PIMs-TS. So this is an evolving concept. So I'll take you through the basics. And then obviously, I was planning to have a question and answer session. So we will try and see how it paints off based on the time. So what does PIMS stands for? PIMS is Pediatric Inflammatory Multisystem Syndrome, and we will talk about the TS later on. So as an introduction to COVID-19, so Corona, essentially, why was it named as coronavirus is because of the shape of the virus. If I go back to the previous slide, this is how the virus looks like and how the outer layer looks like about the shape of the crown. And that is how the name corona had been named for this virus. COVID stands for coronavirus disease. So what is COVID? Essentially, it is one of the types of SARS virus, which we know is the sudden acute respiratory syndrome virus. And this is particular virus which is causing the COVID is named as SARS-CoV-2. So as the name goes, it is one of the 7 types of coronavirus. We all have heard about the origin being the first cases were linked to a large live seafood and animal market in China, but the cause is still unknown to the researchers. The question then arises about being a pandemic where it has been spread to all over the world, why is it not the same virulence in every part of the world? So we all know as medical students, it is kind of a normal for a virus to change, or what we call in medical terms a mutation. So far, they've recognized 2 particular strains, namely mutant L and mutant S. The L type is the one which is known to have been causing the major catastrophe by being very severe in its effect. And the mutant type S is known to be less virulent. Lately, there have been questions arised about, are they really possible to have 2 mutation? But this is again an ongoing thing, as with everything with COVID. Coming in specific to COVID in children, right from the beginning, we knew children were less affected. And then what they say as it is only 2% of the children who are essentially being affected with COVID. And even in this 2%, they seem to be less severe. And what it says is, they have got, they've noticed that whatever severity this condition might be causing, those needing admission to the intensive care are really very rare, and it accounts to only 1%. And it is very good to know, though it is not good neither, the death is even more rare, and they give a quotient of 0.01%. There are reports stating that children have got 56% lower odds of catching an infection compared to the adults. We will come to this, why this lower odds ratio in children later on. But with this fact, what we can say is, if they are already very less in catching an infection, the transmission through children will play a very smaller role. This is significant when talking about children being sent to school and whether they will be spreading an infection. So this is where the significance comes from. I'm going to briefly touch upon the viral shedding, and I'll tell you why in a minute. Throat swabs and the nasopharyngeal aspirates are used to be finding out for the testing for the antigen by the PCR method, and this should be ideally done between day 6 to day 22 of the infection. If a throat swab is being done for the PCR before day 6, there is highly likely chance of having a false negative. Hence the significance that the testing for COVID with the throat swab and the NPA should be done between day 6 to 22. Now, the whole topic for today is going to revolve around the complications of COVID in children in particular. And this is because of the cytokine storm and how this causes the tissue damage in multiple organs. And this is all we are going to be talking about, the emerging phenomenon, which resembles very much the Kawasaki shock. Here to mention, it is not Kawasaki's disease. Kawasaki shock is a particular type complications of the Kawasaki's. Moving on to epidemiology and transmission. When all this started with the COVID-19 in children, what we were seeing was this was mostly affecting the children in the late adolescent. But over the last few months, with us getting more knowledge about and an understanding about the condition, we are seeing children of all ages are affected with this COVID-19. We see right from newborn babies to being positive, neonates, and to the teenagers. The symptom presentation might vary, but it does tend to affect all ages. Interestingly, a large number of these children appear asymptomatic. So that is the good side of things, but the concern rises here. With the absence of widespread community testing, the proportion of subclinical symptomatic children are large. So which means we are definitely not being able to get the accurate epidemiology of this infection. Moving on to transmission, all it's been told is this COVID infection spreads by droplet and aerosols. But there was a talk mid-May saying, is there a possibility of fecal-oral transmission? And this was based on the studies released which said about the virus RNA being detected in stool samples. And this was several weeks after the symptom had resolved. Then we had a research from Germany confirming that whatever the RNA which was detected was from the viral debris, and this is not the active virus. So as of now, it stands, it is going to be the transmission route is essentially from the droplet and aerosols. But again, further studies are still ongoing and we will wait for more information. Now moving on to the susceptibility. As we said earlier on, very little percentage of children are affected. Why is this? What gives the protection in children? There has been several plausible mechanisms which has been put forward, and all of them have been focusing on the lung physiology and the immune function. Let us talk about the first one. It's about the ACE2 receptors. These receptors are present in all cells in all organs of the body. And these are the ones which seems to appear to be the door as the entry point for the virus. The virus, when it is there in the aerosol, it reaches you, and then it appears to directly infect the cells in the body via these receptors, the ACE2 receptors. This is expressed in all organs, including the lungs. But what makes children less susceptible is the cells in the children's lungs express these receptors less than in comparison with the adult lungs. So this is one of the protective mechanism which is being told, has been put forward. Again, this is again being put forward. We are still waiting for more evidence and to confirm these things. The next thing to talk about the immune functions, how do they? With the thymic cells being present in the children, the T cell retention and the cross immunity the children have developed from previous infections to various common cold viruses, this is also being thought to be helpful in making children less susceptible. In particular, T cells, we know they are viral and immunomodulator response, and the higher the T cell, we have got higher interleukin-10, which provides an anti-inflammatory cytokine effect to have less effect of the infection. Here it is important to note this interleukin is an anti-inflammatory effect. But why do we get to this point of the hyperinflammatory syndrome like the PIMS? And this is where it gets interesting to know about the pathogenesis. There are two graphs here, and the one on the left talks about those with the mild disease, and on the right is talking about those one with the severe disease. And what are the factors which contribute to this inflammatory syndrome? And again, note this is an hypothesis. The earlier interferon response with a rapid viral clearance and a less inflammation will mean that child will have only a mild disease or can even be asymptomatic. On the contrast, if they had a delayed interferon response and a slow viral clearance with more inflammation, those are the children who end up with having a severe disease, including the hyperinflammation syndrome. And I will tell about the MISC in a minute. So this is why the possible explanation is why some children are getting milder, are being asymptomatic, and some children are being more prone to develop the hyperinflammatory syndrome. It is not just the viral load about the exposure, it is also about how your body responds and the interkinin, interleukins production. Okay, moving on to more in focus with the PIMS-TS. So as we mentioned in the introduction, I'm practicing in the UK. So we go with the Royal College of Pediatrics and Child Health. And we were one of the first teams to have as the Royal College to come up with a case definition for this PIMS-TS syndrome. So here goes the definition. A child presenting with persistent fever, showing signs of inflammation, be it neutrophilia, having an elevated CRP, and lymphopenia, with evidence of single or multi-organ dysfunction with additional features. So this is the definition which the Royal College of Pediatrics and Child Health published in April about PIMS-TS. It is important to note that we need to exclude any other microbial cause, such as a bacterial sepsis, toxic shock syndromes, and infections associated with myocarditis, such as enterovirus. Here in the UK, we do see a lot of viral infections, and in particular enterovirus causing myocarditis. Hence, it's very important to make sure we rule out both bacterial and viral causes. And the last point is like where I really want to make it clear, and one of the reasons I'm stressing on today's topic is about the PCR testing. So as per the definition from the Royal College of Pediatrics and Child Health in UK, the SARS-CoV-2 PCR testing may be positive or negative. I stress upon it can be maybe positive or negative. So this is about the antigen. And I'm telling you about why I'm stressing in the next few slides. I think like it'll become evident. Now that we know the definition, I think it'll be nice to have a quick background about how things all evolved over the last few months. The first ever case report of PIMS was published in US on the 7th of April, 2020. And this was based on a 6-month-old infant who was admitted with persistent fever and minimal respiratory symptoms. I'm stressing again minimal because it is not classical like an adult patient who has got respiratory symptoms. So since April, over the next few months, there seems to be a small cohort of children who were identified to have developed a significant systemic inflammatory response. Since then, we have got almost 300 plus. As I said, plus is because there are still numbers which have not been reported, who are suspected to have a classical Kawasaki's disease or PIMS-TS cases who are currently being investigated in Europe and North America. From all this experience over a limited period in the last few months, what we seem to understand is the management seems to be more time sensitive, which means there is this important significance that like we should be involving other teams about making onward referrals as soon as possible and not wait for the test results to confirm. I thought it will be a quick refresher of Kawasaki's disease will be useful. We all know Kawasaki's disease has got a specific diagnostic criteria. Those children who have got a fever for at least 5 days and having 4 of the 5 classical criteria are the ones like who have a diagnosis of Kawasaki's disease. I think this picture was quite useful. So those 4 criteria being A, the top left-hand corner picture showing bilateral conjunctival injection, and then picture in B and C shows the change in mucous membranes, and D showing pictures evidence of cervical lymphadenopathy, And in the E, this picture shows about the classical polymorphous rash. And lastly, they do have changes in the extremities, such as peripheral edema and peripheral erythema and periangual desquamation, that is skin peeling. So the classical definition for a classical Kawasaki's disease is fever for at least 5 days, plus 4 of these 5 features to be present. We will slowly understand why we are talking about this PIMS-TS as a Kawasaki's like disease or Kawasaki's shock syndrome. So the pathophysiology of Kawasaki's disease is it is essentially a pediatric vasculitis. Though an infectious cause was generally suggested, we still don't know the definitive cause for the Kawasaki's disease. The treatment, what has been found to be helpful in Kawasaki's disease is use of high-dose intravenous immunoglobulin and oral aspirin. This has been noticed to be affecting children of all ethnic groups, but the highest prevalence was in Japan. And coronary artery lesion was also a very prominent complication of Kawasaki's disease. Now, having heard about Kawasaki's disease, let's focus on PIMS-TS. I've tried to put the clinical features on one side and the infographics on the other side. Essentially, from looking at this picture, you can see the symptoms are very varied, and that covers all of the systems. And I'll touch upon the headache and confusion and the recent evidence which has come up in the last 2 weeks. Coming back to the clinical features. So all of these children are noticed to have a persistent fever of more than 39 degrees Celsius. They mostly have cough coryzal symptoms, shortness of breath, lethargy, and they are reported to be off their feet, and also older children report myalgia. The next one about the abdominal symptoms, which was quite interesting to know, because the next slide I'll tell you about why this is significant. These symptoms are predominantly pain, diarrhea, and vomiting. With these classical triad of pain, abdominal pain, diarrhea, and vomiting, many of these children were initially presenting to the surgical team as suspected appendicitis. And what had evolved was, on table, they found the appendix was normal, but they did notice that the colon looked inflamed. And that is how we started working upon the non-surgical causes, and PIMS was one of them. And these children do have rash and conjunctivitis. And again, this last part is where it's really important about children presenting with shock features. And this is where it talks about having a cardiac involvement. When they present with shock, always think about having cardiac involvement of the PIMS-TS. So the clinical features will be, they will be hypotensive and also having high heart rate. Generally in pediatrics, blood pressure will be the last thing we will all be worried about when you present a case. Sorry, my slide seems to have gone. Sorry, can you hear me?
Yes, sir.
Sorry about the technical thing. I don't know what happened. Okay, let me resume. As I said about the hypotension, in general pediatrics, we normally don't worry about the blood pressure. That will be the last thing we will ask in a clinical examination. But here in this presentation, with the shock in mind, always look for tachycardia and hypotension. Another learning point from a general pediatric point of view, tachycardia, unexplained, needs to be ruled out about an infection as an until proven otherwise. If they have got a fever and a pain, that can cause tachycardia. But if you're not able to explain a tachycardia, please do not send the child home. This is again a general pediatric perspective. Now moving back to PIMS, as I said earlier on in the definition, always look for examination for other possible focuses for the sepsis. And this again includes a cardiac examination as well. Having heard about the clinical features, now I was going to talk about the laboratory features. But before that, this infographics again was quite useful. Those which are on yellow fit in with the Kawasaki's disease. And hence we are talking about Kawasaki's like phenomenon. So what do these children have? They have bulbar conjunctivitis in 90%, mucosal involvement, cervical lymphadenopathy, and mesenteric adenitis, lymphadenitis as well. They've got skin rash, and they've got coronary involvement. But if you look at it, respiratory symptoms are present only in almost 34% in comparison to the gastrointestinal involvement of 83%. So this is why there was at one point saying like, please do take abdominal symptoms quite seriously when we were trying to triage the patient with just fever and respiratory symptoms. So it is fever and it can involve any symptoms as such. And if you remember from the last slide, I was telling about the recent evidence, which is talking about the neurological. We did know that these children, as we said in the earlier slide, had headache and they had some confusion. But what has now become evident is like those children who end up having an MRI for whatever reason, thinking about encephalopathy in this current situation, they did find some typical MRI signal changes, and which has been added on to the diagnostic features as well. One thing I did want to mention about like this particular presentation of like having off feeds, as I did earlier on mention about smaller children having different features, especially those children who are under 1, who were presenting with fever. There was also reports of like them going off feed and having some apneic episodes. And this has been looked into as a feature for presentation in the neonatal age group. Now moving on to the laboratory features. So the way we are doing it at the moment is like when children come in with fever and then any of these symptoms, we start off with the general panel like we will normally do. And then if there are concerns about any of those numbers, then we will go on to the panel like where we talk about the PIMs-TS. So we will normally do a full blood count, urea and electrolytes with the renal function, and also for looking for the CRP. So this will be the initial baseline investigation for anyone coming in with a fever. If you notice a raised CRP, I'm talking about like those who are having high CRP in the hundreds. The normal threshold is up to, the normal range is usually between 0 to 10, but if it is up to 50, we will accept for a viral infection. But these children with PIMS-TS classically have a CRP in their hundreds, and they tend to double in the next few days. And in the full blood count, different to the adult picture, they tend to have a lymphopenia and a neutrophilia, and the platelet counts can be normal or low. And there was also some renal involvement, and which will be shown as like renal dysfunction, and also hyponatremia like an SAADH picture. So this will be the picture, and then looking at the clinical presentation, then we will think about like having further investigations added. That will include ferritin, which again will be raised significantly. And this is also thought about as an inflammatory response, acute inflammatory response, same as the CRP, the C-reactive protein. Along with this one, we also notice that the children have had significant deranged clotting, and they will have raised D dimers. I'll tell you about the numbers in one of the examples I'll be talking later on. Those children who have a cardiac involvement, those children will have a raised troponin and a BNP. And these are investigations which is very rarely used in pediatrics. These are mostly used in adult patients with chest pain, angina, etc. But for us to do a troponin, like it means like, this is a trend which has been seen. And those are the children who present with shock, and there is a definite cardiac involvement. We are now trying to save some serum, because any child who comes in with a fever of unknown origin, we always routinely try and save some serum to look into further etiologies in progress. Now this slide is like something which I want to spend a little bit longer time on rather than like what you see on the screen. So we spoke about the clinical features and lab features, but in current situation with the COVID, we do two things. One is the PCR, which is either the throat swab or the NPA, which is looking for the antigen. And the other one is looking at the antibody, which means your body has already got the infection. And that is how, like you say, you had an exposure to COVID. So if you look at this, what we have seen is the antigen tested by the PCR has often been negative. But these children going on for a few days down the lane, they do have the antibodies present in them. I hope like I've made sense in like what I wanted to stress here. So invariably of like what the clinical and lab features are suggesting, don't be put off by saying if the PCR is negative. For example, the throat swab or the NPA swab is negative for COVID, does not mean they have not had COVID. For some reason, these children do not show up as having antigen being present, but they do have the antibodies in most of the children. And this is one of another reason why I wanted to talk about. Moving forward, now that we have spoke both about Kawasaki's disease and PIMS, I thought it will be a nice dissection to look into the similarities and differences and get a better understanding of why we are talking about, are these phenomena the same? Now talking about the similarities, both these conditions, be it Kawasaki's disease and the PIMS-TS, are relatively uncommon and cause is not known. And there is no single specific diagnostic test to say this is it. And both of them have been found to cause damage to the coronary arteries. And we do know both of the conditions can lead to shock, and this is due to the impaired heart function. Now looking at the differences, how are they different? Kawasaki's disease mostly affects under 5s. And as I said at the beginning, we thought PIMS is like mostly affecting older children, but now we know it affects all age groups. And regarding the symptomatic presentation, the gastrointestinal symptoms predominate in the PIMS-TS, and it's especially as abdominal pain. And again, like this temporary correlation with the SARS-CoV, we don't know, and the link is not fully been established, hence the name of PIMS-TS, which stands for Pediatric Inflammatory Multisystem Syndrome, and the TS stands for Temporary Association with SARS-CoV-2. Now it will be always interesting to have some evidence-based literature discussions. This is one of the papers which was published from France, and this talks about the Kawasaki's like multisystem inflammatory syndrome in children. And what I wanted to focus on was, like, I mean, this was again like a small number to start off with if you criticize the paper as it, but again, this is early days, so this is quite acceptable. And they were talking about the features of the Kawasaki's disease and the Kawasaki's disease shock syndrome, because at that time, we didn't have any fancy names such as PIMS or the MISC. And all these 21 patients had noticeable gastrointestinal symptoms. That is when we started alerting, saying it is not always just the respiratory symptoms. Do watch out for gastrointestinal symptoms. So always like have a high threshold to look into more details. And what I wanted to signify is that almost 8 out of the 21 patients had positive PCR results. So it's only 8 out of the 21. But on the contrary, 19 of the 21 had antibodies. So this correlates with like what I was trying to establish before. So antigen being negative does not mean they have not had a COVID exposure. These children have got antibodies, so they do have had some exposure. And good to know that the clinical outcome, this was again in the early days, was favorable in all patients and still holds good. All of them make a good progress. So after this initial paper, then the discussion started coming about, should we name them as PIMS or KDSS, which is Kawasaki's disease shock syndrome. So, but I don't know what is in the name. So this paper was published in JAMA, which is a Journal of American Medical Association. And what they had tried to say again was, they were looking in a study at 58 children, slightly more, and those were included based on the criteria from the UK's definition, CDC and WHO's definition. And they were particularly taking these children without requiring proof of having a COVID exposure and investigated the value of the requirement in an analysis. So this again supports that the results from the PCR test were positive only in 26%. So the antigen was found to be present only in 26% in comparison with almost 87% having the antibody. So it is not just based on the antigen. We want to say if you don't have an antigen, you're not got COVID. Please don't take it. You have to wait and treat it as COVID still. And then like these children are found to have mount an antibody response. And what is MISC? Like the PIMS, we named it in UK. In America, they came up with this name of Multisystem Inflammatory Syndrome related to COVID. And this paper is from New York. I just like wanted to introduce this concept of having a different name. And essentially this again talks about the same thing. But I just like wanted to introduce the concept of the MISC as well, which is Multisystem Inflammatory Syndrome related to COVID. And again, if you are to take one more message from here, this is when like things came into light saying, unlike Kawasaki's disease, which was more common in Japan, children of the BAME origin, which stands for the Black, Asian, and ethnic minority children, those were the children who are predominantly seem to have been affected by this hyperinflammatory post-COVID syndrome. Having spoke about all the different definitions, I thought it will be a good way to put them head on head. So on this, we have got the RCPCH definition from UK, and this was published in April. And on the lower bottom, we have got the MIC, which is a multisystem inflammatory syndrome. And this was from the CDC, which stands for Center for Disease Control and Prevention. And this definition was in 14th of May, 2020. I'm going to concentrate not just on the first and the second, but I'm going to be more focusing on the third point. And if you look at the RCPCH definition, they talk about the SARS-CoV-2 PCR testing may be positive or negative. And when you compare it with the one from the US guidelines of the CDC, it talks about positive for current or recent COVID-2 antigen by RT-PCR serology or an antigen test, or COVID exposure within 4 weeks of the onset of the symptoms. So here it clearly says the antigen may be positive or negative. This is from the definition. And in the definition here, it talks about positive for current or recent infection by antigen test or having a COVID exposure within 4 weeks of the symptoms. Let us put this in contrast with the WHO definition, which the rest of the world follows. Again, let's focus on the last point here. It talks about evidence of COVID by having the antigen in the PCR testing or serology positive or likely contact with COVID. Here it does not say that the antigen can be negative. My point I wanted to put forward was, I think this is where we are possibly not being properly guided in looking whether these are all related to COVID or not. Let us say if this is the only guidance like we got in front of you, and then you've been looking at evidence of COVID positive is being there, and then if the antigen test comes back as negative and there has been no contact with patients with COVID, I'm not going to be thinking along the lines of COVID. So this is one of the important points I wanted to stress upon about how the WHO definition could have been slightly modified to make it more clearer to all of us. Finally, moving on to the management. I think the general principles of management is like what I'm going to be briefly going through. All of these children benefit from high quality general pediatric intensive care. Most of them are able to manage with just a high dependency care, but it's very minimal who need intensive care. And those are the children who present with shock and who benefit from intravenous immunoglobulin, having a short course of pulse IV methylprednisolone and aspirin. We know that the commonest presenting feature in critically ill children is shock. So always think outside the box. Just because it is COVID, we wouldn't be missing out on other children who present with meningitis or any other septic shock. So please have that in mind. The respiratory failure is not a common feature which is seen in PIMS-TS. Abdominal imaging may be valuable to exclude significant abdominal pathology. And this is where, as I was talking earlier on, the surgical colleagues need to be aware that like not all that present with the classical features of appendicitis is going to be appendicitis. So these children do end up in theater having their appendix removed, and in histology, they found it was not inflamed, and they do the general pediatricians. Those children who got cardiac features, we do say recommend for having a regular echocardiogram to track the cardiac dysfunction and monitor for the coronary artery abnormalities. Always, it is useful to have an MDT. So the multidisciplinary team approach should be encouraged, which is involving all the specialties which might be useful in giving an advice, be it cardiology, infectious disease, and here we use immunology along with rheumatology hand in hand, depending on where you work. This slide I just like put forward to say, like, again, every area region will have their own pathways, and this is like what we do in London region. And I'm going to quickly, like, this is a very busy slide. I don't expect you to go through all of this, but I thought I'll take you through what is really important. So child presenting with shock, if it is yes, then do think about PIMS-TS and then have a discussion of the MDT earlier on. And these are the children who will benefit from intravenous immunoglobulin and the pulse methylprednisolone. If the children are not in shock, but they fulfill the criteria of the Kawasaki's disease, then follow the Kawasaki's disease guidance. If the child is not in shock and is not fulfilling the Kawasaki's disease, please follow this pathway where it talks about other undefined inflammatory presentations. And then follow the discussion of the MDT. And again, based on the discussion, you might be guided to use the intravenous immunoglobulin or the steroids. finally, talking about the outcome. So how do these children respond to treatment? This is again from a very limited knowledge. Short term, we know they are making a very good progress. Their length of stay in the pediatric intensive care has been generally short, between 3 to 4 days, and great majority of the patients make it and then they are perfectly fine. Talking about the long-term complications, it is very limited information is available, so we'll have to wait and see how things turn out. And again, as I mentioned before, practice may change in the next few weeks and months as more evidence becomes available. And to be aware, as an evolving condition, all these children who are suspected should be considered for recruitment in research studies because we are still learning and we would want to know and get more knowledge about this. Touching about research trials and vaccines, where does this apply? Majority of these PIMS-TS children just need supportive HTU care and nothing more than that. But unfortunately, there is currently no specific treatment which is available or recommended, and there are many trials which are going on. I'm going to be talking about just the recovery trial, which I'm involved with, and this recovery stands for Randomized Evaluation of COVID-19 Therapy. And this is a study looking at multiple potential treatments. When the study was started, we did involve all the other medicines which was in the adult limb, including the hydroxychloroquine and all those things. But currently, what we are trying to do is, these are the medications which we have been trying to see if it makes a difference. And those include azithromycin, dexamethasone, convalescent plasma, and tocilizumab. So convalescent plasma is, as you know, I'm just going to say one line about it. This is where blood is taken from a patient who is found to have an infection. So they would have mounted the antibody, and that is being used to produce, that is given into the patient to see if they are able to mount more antibody response. And talking about vaccines, again, I wouldn't say still early stages of the human trial. I think we are making steady progress, and we are hopeful that we will have something available by the end of the year, hopefully by September, October. And before I finish, I thought I'll just give an example. But again, this is a patient who had gone through the whole journey of full-blown PIMS-TS. So this is not what you're going to be facing in, day out, but this is someone who's made the full journey of going through the extensive complications and how they made a recovery. So talking it through, it is about an 11-year-old girl whose initial presentation to hospital was with 3-day history of fever, abdominal pain, diarrhea, myalgia, and having a neck swelling, which was the lymphadenopathy. She was a bit tachycardic, had a temperature spikes of 39 degrees, and not much tachypneic. The respiratory rate was between 20 to 30, which is acceptable for an 11-year-old. And focusing on the inflammatory markers, CRP right from the beginning was significantly raised in 150, and it increased very quickly to 300. The D-dimers talks about the deranged clotting. It was already raised in the 2000, and the next day it made it to 5,000. The white cell count shows a clear picture of lymphopenia, which is what the trend we have been seeing in PIMS-TS children, and a neutrophilia. Platelets was initially normal, and then it started dropping. This child was found to be having antigen positive, so there was no doubt about it that we are dealing with a post-COVID syndrome or a COVID infection. She did have a surgical review given the feature of abdominal pain and diarrhea, and had an ultrasound scan which showed there was free fluid in it. And the CT of an abdomen showed thickened bowel walls and lymph nodes in there. So this takes us to the differential diagnosis of sepsis with an abdominal focus, or was it COVID we were dealing with, or should we be thinking about the other inflammatory conditions like the toxic shock syndrome? So the treatment was started with antibiotics, and she needed multiple fluid boluses. And in spite of having a 60 mils per kg fluid boluses, she continued to deteriorate, and hence she needed to be transferred to the pediatric intensive care because she needed multiple inotropic support to maintain her blood pressure. She did receive intravenous immunoglobulin, and an echocardiogram performed at the tertiary hospital confirmed she had a severe ventricular dysfunction, and her troponin was sky high in 2,500. Because of making poor response and with this picture, she was transferred further to a specialist center for receiving ECMO, which stands for extracorporeal membrane oxygenation. This is where she needed 16 days of ECMO. This is quite significant, and had high dose of methylprednisolone. And the biopsy of the heart confirmed she had myocarditis, which was predominantly lymphocytic. Following further continuation of treatment, She was finally successfully extubated and making good response, and she's made a recovery now to home. So this is the worst case scenario you would think about, but what I wanted you to understand was, so this will be the picture she had gone through, but still there is recovery and expectation for the patients to be discharged home. Again, let me make it clear, this is not what we see every day, but this is what can happen. So finally, I would like to finish off by summarizing the presentation. Right from the beginning, we knew there was a disease heterogeneity. So there was different presentations. So the aim of the talk today was to raise awareness among everybody as clinicians. So any patient who presents it, have a fever, have a high index of clinical suspicion, and this will help in improving outcomes. We know the common feature in this condition is with fever, but there are always other inflammatory conditions in pediatrics. So do think about it. Not all that we see this time of the year with fever is going to be COVID. There are still other inflammatory conditions such as Kawasaki's, toxic shock syndrome, bacterial sepsis, and macrophage activation syndrome. The diagnosis relies on clinical criteria and laboratory findings. As I said in the beginning, so think about all the clinical pictures they're presenting with. Not all of them follow the same. There can be one predominant symptom in one child, not in another. And the laboratory findings tend to be mostly following the same pattern. Again, depending on where you work, the treatment protocol will vary. So follow your institution protocol. Finally, the potential link with COVID is not fully established or not well fully understood. Hence the reason we are calling this again as PIMS-TS, where the TS stands for Temporary Association with SARS-CoV-2. That brings to the end of my presentation. RCPCH guidance is where I would point people to look into if you want to read more about this. And also we closely follow the guidelines given to us from the Pediatric Intensive Care Society. I think like that brings to the end of my presentation.
Thank you, sir, for enlightening us about pediatric multisystem inflammatory syndrome in post-COVID patient. It was really a great session, and we are so excited about this session. And yes, sir. So this will be uploaded in the YouTube channel by as soon as possible, sir. We due to some technical issues, we didn't go live, so it will be uploaded in the YouTube channel soon, sir.
Sure. Thanks a lot. Thank you so much.
Yes, sir.
And I'll get in touch with Raghu later on. Thank you. So shall I leave the call now? Yeah.
Thank you, sir. Thank you so much, sir.
Yes, sir.
Thanks, Raghu.
Yes, sir.